Hello, everyone. It's lovely to see you all again, even though the lecture is still online. Today, I'm going to talk about haematopathology. I'm going to cover diseases of white blood cells and diseases of the spleen and the thymus. I'm going to skip the parts of red blood cell and platelet pathologies, as you have already learned about them in different lectures. The hematopoietic system is divided into the myeloid part and the lymphoid part. The myeloid part includes the bone marrow and the cells within it, whereas the lymphoid part includes the thymus, the lymph nodes, and the spleen. Both the myeloid and lymphoid cells originate from one common hematopoietic stem cell. A stem cell has two important properties, which are self-renewal and differentiation. As the cells differentiate, they will lose their self-renewal property. So as we can see here, the self-renewal is the most in the hematopoietic stem cell. But as it differentiates into a more matured progenitor, so it will become less self-renewal. So from the stem cells, these cells will develop into two lineages, the lymphoid lineage and the myeloid lineage. The lymphoid lineage will develop into T cells, B cells, and NK cells, whereas the myeloid lineage will develop into different granulocytes, platelets, and erythrocytes. So pathology of white blood cells includes leukopenia, or a decrease in white blood cells, and leukocytosis, or an increase in white blood cells. Leukocytosis can be either reactive or non-neoplastic, or neoplastic. Leukopenia, the decrease in white blood cells. So the most important leukopenia may be neutropenia, or the decrease in neutrophils, which can also be called agranulocytosis. The causes of neutropenia includes inadequate or ineffective granulocytosis, accelerated removal or destruction of neutrophils, and also drug toxicity, which is the most common cause of agranulocytosis. So for inadequate or ineffective granulocytosis, granulopoiesis, the causes include bone marrow suppression, hematopoietic stem cell suppression, which can be seen in aplastic anemia. So some common causes of aplastic anemia are like drug toxicity, or some infections. There are different causes, or it can also be idiopathic. And so infiltrative bone marrow disorders, including tumors or granulomatous disease. The most important granulomatous disease in Thailand is tuberculosis. And suppression of committed granulocytic precursors, including after drug exposure, and also ineffective granulopoiesis, which can be seen in megaloblastic anemia. This is the result of vitamin B9 or B12 deficiency, and also MDS, which stands for myelodysplastic syndrome. I will mention about this again later on. And also rare inherited conditions, including Costman syndrome, which impairs differentiation. For the accelerated removal or destruction of neutrophils, the causes include neutrophil injury caused by immunologic disorders such as SLE, systemic lupus erythematosus, or drug exposure, and also splenic sequestration. For example, for the patients with liver cirrhosis will develop will have splenomegaly, and too big spleen is quite harmful because the blood cells will be sequestered within the spleen, and the sequestered blood cells will be destroyed. So the patients with liver cirrhosis can have pancytopenia, anemia, leukopenia, and also thrombocytopenia as a result of splenomegaly. So the mechanism is portal hypertension. So splenomegaly is a sign of portal hypertension. And another cause of accelerated removal or destruction of neutrophil is increased peripheral use in overwhelming infections. So severe infections may result in leukopenia, even though just like general infections will rather cause leukocytosis, not leukopenia. But in severe infections, leukopenia or neutropenia can be seen. For drug toxicity, which is the most common cause of agranulocytosis, it can be dose dependent. It can be in a dose dependent fashion. That is, many chemotherapeutic drugs, or it can be idiosyncratic. For example, chloramphenicol and sulfonamides. In patients with leukopenia, severe infection may occur when the neutrophils are less than 500 cells per cubic millimeter. And the patients may have malaise, chills, and fever, often with marked weakness and fatigability. In some cases, the characteristic lesions may be seen. The patients may have ulcerating necrotizing lesions of the gingival, buccal mucosa, or the pharynx. And in severe neutropenic patients, there may be severe life-threatening invasive bacterial or fungal infections. So because they are at high risk for deep candida and aspergillus infections. The treatment includes broad-spectrum antibiotics at the first sign of infection, and sometimes the patients may need to have granulocyte colony stimulating factor treatment. This factor will stimulate the granulocytosis, granulopoiesis. For leukocytosis, it can be either reactive or neoplastic. For reactive leukocytosis, the causes include increased production in the bone marrow, increased release from the marrow stores, decreased margination, and decreased extravasation into tissues. Increased production may result from chronic infection or inflammation, as you all have learned already that inflammation or infection will stimulate cytokine production from the immune cells, and those cells will produce different growth factors, different cytokines, and those substances will simulate leukocytosis. Paraneoplastic syndrome leukocytosis may be paraneoplastic as well. For example, in Hodgkin lymphoma, the neoplastic cells are not so many within the lesion, but they produce a lot of cytokines to call reactive inflammatory cells into the lymph nodes, resulting in lymph node enlargement, even though the neoplastic cells are very few, and it can be growth factor dependent. And myeloproliferative disorders are also a cause of leukocytosis. For the increased release from myelostones, the causes include endotoxemia, infection, and hypoxia, and also the decreased margination. Normally, in the blood circulation, there are so many lazy white blood cells. They do not like to travel throughout the body. They would like to stay on the blood vessel wall. And so in times of exercise or catecholamine exposure, these lazy cells will enter into circulation again, enter into the center of bloodstream again, and so the individuals will have leukocytosis. And glucocorticoid or steroid, glucagon, will cause decreased extravasation into tissues. So if we do the blood test in patients with glucocorticoid exposure, we may see leukocytosis, even though the white blood cells remain within the blood circulation and they do not go out to the place where they are needed. So that's why the patients with the history of glucocorticoid exposure will have a tendency to get infection. Leukocytosis can be classified into different types according to the predominant type of cells. So if the predominant type of cells is neutrophil, so it is neutrophilic leukocytosis. It is seen in acute bacterial infection, especially those caused by pathogenic organisms or organisms that cause pus formation, and sometimes neutrophilic leukocytosis can also be seen in just like different causes of inflammation, for example, myocardial infarction and burns. For eosinophilic leukocytosis or eosinophilia, as you have already learned that eosinophils are actively involved in allergy or type 1 hypersensitivity and also parasitic infestation. So it is not surprising that eosinophilia is seen in those with allergic disorders such as asthma, hay fever, and also in patients with parasitic infestations. And additionally, this condition can be seen in drug reactions and certain malignancies, including Hodgkin lymphomas and non-Hodgkin lymphomas, and also autoimmune disorders and some vasculitis, and also arthroembolic disease. For basophilia, it is very rare. But if we detect basophilia or basophilic leukocytosis, we just have to find out the cause. because it is often indicative of a myeloproliferative disease, such as chronic myeloid leukemia. Monocytosis are increased in the number of monocytes within blood circulation. So monocytes, when they enter tissues, they will become macrophages or histocytes. So as we know that histocytes or macrophages are involved in different types of inflammations, including chronic infections, bacterial endocarditis, autoimmune disease, and also inflammatory bowel disease. So these conditions are chronic inflammatory diseases. And lymphocytosis. Lymphocytes are involved in immunity against viruses. So it is not surprising that important causes include chronic immunologic stimulation in TB, in viral infections, and also in some bacterial infections, as lymphocytes are involved in adaptive immunity. For patients with severe infection, we may see abnormal features within the neutrophils, such as toxic granules. These are primary granules within neutrophil, and just like when in severe infection, the development of neutrophils may have some problem. So we may see abnormal granules like this, and sometimes we may observe dough body. Right? So these dough bodies are aggregates of residual RNA within the cytoplasm. This slide demonstrates the development of lymphocytes. Lymphocytes develop from hematopoietic stem cells, right? And some hematopoietic stem cells will be committed to the lymphoid lineage, and the lymphoid lineage, like some within the lymphoid lineage will remain in the bone marrow and develop into B cells, into pro B cells, immature B cells, and these immature B cells will migrate into lymph nodes to become more mature B cells and develop into plasma cells producing antibodies. For the T cell lineage, just like the cells will migrate to the thymus and develop there. So the thymus is the kindergarten or maybe the school or university of the T cells. And the T cells will develop into gamma delta T cells and alpha beta T cells. For alpha beta T cells, just like these cells will develop into CD4 and CD8. And some of these cells will develop into NK cells, which are actively involved in the ADCC process. And it is also the first cell fighting against viral infection. So NK cell is very important in different types of infections and also in the tumor immunity as well. In the lymph nodes, we will see the structure like this. There are multiple afferent lymphatic vessels. The afferent vessels will enter the lymph node just on the peripheral areas, on the capsule side, and the lymph will exit the lymph node via one efferent lymphatic vessel at the hilum. So this structure is very important for you to to memorize. So if I ask which areas in the lymph node will be involved by metastatic carcinoma first, so the answer will be the subcapsular area, as the afferent lymphatic vessels enter the lymph nodes on the capsular area, on the capsular side of the lymph node. And within the lymph node, we can see different zones, cortical zone, paracortical zone, and also medullary zone. The cortical zone is composed of primary lymphoid follicles, secondary lymphoid follicles with germinal center in the middle. So the cortex is the zone for B cells. It is B dependent. And the deeper to the cortex is the zone called paracortical area. This area is for T cells. It is T dependent. And in the medulla, just like it is also the zone for B cells. It is B dependent. Within the sinuses, within the lymph node, there are many sinuses also, and the sinuses contain different white blood cells, contains red blood cells, contain macrophages. So in reactive lymphoid hyperplasia, so the different zones may be expanded depending on the causes. For example, if in viral infection, we know that the main immunity against viral infections is adaptive immunity. So we expect to see T cell proliferation. So the paracortical area will be expanded. Whereas in some bacterial infections, in some particular types of infection that require antibody production to fight against the infectious agent, so we may observe cortical or follicular hyperplasia. And in some cancer, even though we don't know exactly why it is like this, we may observe sinus hyperplasia or sinus histiocytosis. So this is a gross anatomy of the lymph node. We will see a nodule like this. So it is in normal lymph nodes are quite small, should be less than half a centimeter or 1 centimeter, depending on the area in the body. And at low magnification, we should be able to observe different areas. We may be able to see the cortical area, paracortical area, medulla, and we will observe follicular lymphoid follicles within the cortex like this with germinal centers. So these are secondary lymphoid follicles, and here this is normal secondary lymphoid follicle. One follicle will have the germinal center like this. This is called germinal center. In this area, we will see centrocytes, centroblasts, plasmablasts, immunoblasts, these cells. And one important feature that we should observe within the normal or reactive germinal centers is these tingible body macrophages. These macrophages are engulfing the apoptotic bodies. in this area, the B cells are actively proliferating, and some of them will die by the apoptotic process, and those dying cells will be engulfed by these macrophages. So normal reactive germinal centers contain these tinctural body macrophages. So if we imagine that the background is black, so we are seeing the starry sky pattern. Starry sky pattern. So it's like we see tinctural body macrophages as the stars, and the background is black. So this is normal reactive germinal center. So if we see the feature like this, this is likely reactive follicular hyperplasia. And the germinal one lymphoid follicle contains the germinal center in the middle, and a few layers surrounding the germinal center is mantle zone, and surrounding the mantle zone is marginal zone. So reactive germinal centers will have very clear-cut boundary like this, and we should be able to observe starry sky pattern like this. But in abnormal or in neoplastic follicular pattern, so the germinal center will contain no tinctural body macrophages, and the boundary is blurred or fuzzy. So these two features are very helpful to differentiate reactive germinal centers from neoplastic germinal centers. So lymphadenitis is very common, very common. The causes include local infection because the lymph nodes receive lymph fluid from the infected site, and so the lymph nodes may become inflamed, become infected, and we will observe lymphadenitis. So just like the lymph node is swollen, is bigger, and we may be able to observe signs of inflammation. As you have learned already, that signs of inflammation include ปวดบวมแดงร้อน เสียหน้าที่ right? Pain, swelling, redness and heat, and also loss of function. In systemic infection, we may in the patients with bacteremia or viral infection, we may be able to observe lymphadenitis as well. So the clinical features include enlarged tender lymph nodes, redness of the overlying skin, and fluctuance if there is abscess formation. And so complication includes the drainage of the abscess if the infection is severe, and if the infection affects the lymph node also. So just like we may be able to see abscess within the lymph node, and the pus may drain to the skin, so we may be able to see sinus tract. So in chronic non-specific lymphadenitis, we have to distinguish the zone that is expanded. So if we see that the follicular area or cortical area is markedly expanded, markedly enlarged, the cells within the follicular areas are markedly proliferating. So that is follicular hyperplasia, which can be observed in those with rheumatoid arthritis, toxoplasmosis, or early HIV infection. Sometimes the areas that are mostly proliferating is the paracortical area, deeper within the lymph node. So this the condition may be caused by viral infection, for example, infectious mononucleosis. And again, I would like to review that. I would like to say it again that paracortical area is the zone for T cells, and T cells are involved in the fighting against viral infection, particularly infectious mononucleosis. And when the sinus areas are markedly expanded, that condition is called sinus histiocytosis or reticular hyperplasia. It is quite non-specific, but it can be seen in lymph nodes draining tissues with epithelial cancers or with carcinomas. So it is noteworthy that when lymph node enlargement is seen within a patient with cancer, it is not necessary that the lymph nodes are already metastasized or involved by the cancers, because sometimes the lymph nodes are enlarged due to sinus histiocytosis. That is why histologic examination is required for staging, TNM staging. For example, sometimes breast cancer patients may have axillary lymph node involvement, even though the cancer may not have involved the axillary lymph nodes yet. So it requires pathologic or histologic examination of the lymph nodes to see whether the enlargement is due to lymph node involvement of the cancer or sinus histiocytosis. The first picture demonstrates enlargement of the follicular area. We see that this secondary lymphoid follicle has the clear-cut zone of the germinal center, which contains which shows a stylus sky pattern, right? So this one is likely to be a benign lymphoid follicle because it has a clear-cut boundary and it shows a stylus sky pattern. And we can observe maybe a few layers of the mantle cells in the mantle zone, and also multiple layers of the bigger zone of the bigger marginal zone. These areas are the areas for B cells. So the lower picture highlights the gingival body macrophages. We see these macrophages are have eaten up the apoptotic bodies. So these cells are called gingival body macrophages. So this is non-specific follicular hyperplasia, which can be seen in rheumatoid arthritis, toxoplasmosis, or early HIV infection. On the right side, we may observe this one is a follicular area, and we see that the paracortical area is predominantly expanded. So this one is paracortical hyperplasia, which can be seen in viral infection, such as infectious mononucleosis, which is the infection of EBV. EBV is one common cause of lymphomas, both Hodgkin lymphomas and non-Hodgkin lymphomas. And the lower picture on the right hand is sinus histiocytosis. It is the expansion of the sinus area. It is the proliferation of the maybe histiocytes within the sinuses. So we call this condition sinus histiocytosis or reticular hyperplasia, which is quite non-specific, and it can be observed in the lymph nodes draining from tissues with cancers, with carcinomas. And this slide, I would like to highlight to show you how to distinguish between reactive lymphoid follicles and neoplastic lymphoid follicles. On the left side, we can see at low magnification that the lymphoid architecture is still intact. We can see the cortical area, we can see the paracortical area, we can see the medulla, we see different sinus areas, and we see that the follicles are quite vary in size, So these features can be seen in reactive follicular hyperplasia, and at the higher magnification, we expect to see a starry sky pattern, which is the presence of the tingible body macrophages. So these macrophages will be like stars in the dark sky, right? So we see the starry sky pattern or the presence of the tingible body macrophages, and the boundaries should be very sharp, because of the presence of the mantle zone. So these features are for follicular hyperplasia. In contrast, in follicular neoplasms, follicular lymphoma, we will see that the size of the follicles are more uniform, quite more uniform. We will see that the architecture of this lymph node is totally destroyed. We can explain this phenomenon as effacement of nodal architecture. So we cannot see where the cortex is, where the medulla is, where the sinus areas are. So the architecture is totally destroyed. You see that the follicles are quite uniform in size, and at a higher magnification, we observe that the germinal center has a fuzzy boundary. We cannot draw a line to distinguish the germinal center from the mantle zone, because we don't see mantle zone here, and we don't see tingible body macrophages. As a teaser, we don't observe tingible body macrophages because the pathogenesis of follicular lymphoma is increased production of BCL2. BCL2 blocks apoptotic process. So the cells never die. Because the apoptotic process is totally blocked by the increased production of BCL2. And I will mention about the pathogenesis of follicular lymphoma again soon. So now I'm going to talk about maybe the biggest part of the lecture, the neoplastic proliferations of white cells. Neoplasms of white blood cells can be divided into three big categories. The first one is lymphoid neoplasms. They are the neoplasms of B cells, T cells, or NK cells. The diseases are called leukemia or lymphomas. Leukemias are the disease we call leukemias if the main clinical picture is the presence of malignant white cells within the blood. So emia means the blood, right? So leukemia, leukocyte, malignant leukocytes within the blood. Whereas if the condition, the main clinical feature is a mass, maybe a lymph node or a mass within an organ. So the condition and the mass is composed of malignant white blood cells. That condition is called lymphoma. Oma means mass, right? Or mean neoplasm. So it is a mass. It is one maybe one clue. So there is no benign neoplasm of white blood cells. There is no benign neoplasms of white blood cells, even though some neoplasms are quite indolent, whereas some are quite aggressive. But we just consider that the conditions are malignant, with very few exceptions. And the second group of white blood cell neoplasms is myeloid neoplasms. So myeloid, just like the myeloid the precursor of granulocytes, right? It is myeloid is a haematopoietic cells within the bone marrow, So it is the neoplasms of early haematopoietic progenitor cells within the bone marrow. Myeloid neoplasms can be classified into just like the most benign one is myeloproliferative disorders, chronic myeloproliferative disorders. So in these diseases, there is increased production of one or more terminally differentiated myeloid elements. So there are many types of chronic myeloproliferative disorders depending on the major predominant elements of the myeloid cells that are increased. For example, if the bone marrow is composed predominantly of the erythroid precursor cells, and the patients will have a lot of red blood cells within the body, that is polycythemia vera. If there is too much megakaryocytes, too much platelets within the blood circulation, that is ET, essential thrombocytosis, or essential thrombocythemia. If the main component of the neoplastic cells in the blood is mature, different stages of mature white blood cells, and the bone marrow contains a lot of white blood cell precursors, a lot of granulocytic precursor cells, that is CML, or chronic myeloid leukemia, which is now required genetic test, cytogenetic test, to confirm the diagnosis. The second group of myeloid neoplasms is myelodysplastic syndromes. Myelodysplastic syndrome. Dysplastic means abnormal growth. In myeloproliferative disorders, we expect to see normal differentiation, increased production. With normal differentiation, we will see too much precursor cells within the bone marrow. We will see too much cells or blood components within the peripheral blood. for the myelodysplastic syndrome, dysplasia, abnormal growth, right? So we expect to see abnormal cells within the bone marrow, and the dysplastic change or abnormality of those cells result in ineffective hematopoiesis. In these conditions, we expect to see increased cellularity within the bone marrow and decreased or cytopenia, decreased cellularity within the peripheral blood. And the last group, acute myeloid leukemias. Acute myeloid leukemias. So the common feature, the common pathogenesis of acute myeloid leukemia is the maturation arrest. So we will see young cells, immature cells within the bone marrow. They are blasts, they are myeloblasts within the bone marrow, and those blasts will be leaked into the blood circulation. So we often see a lot of blasts, myeloblasts within the peripheral blood as well. So the clinical picture is too many precursor cells within the bone marrow, and also too many blasts within the blood circulation. So this is just a basic principles of different types of myeloid neoplasms. And the last group of white blood cell neoplasms is histiocytosis, or proliferation of macrophages or histiocytes or dendritic cells. Just like histiocytosis are quite rare, so I don't want to focus too much. Just know the general concept about it. So one common pathogenesis of white blood cell neoplasms is chromosomal translocation. It may be a bit boring, but it is important because if we know the pathogenesis, we will understand why we see the features in particular types of lymphomas or leukemia. And some chromosomal translocations are used for diagnosis and also for treatment. So the chromosomal translocations may result in increased production of normal proteins or synthesis of fusion oncoprotein. For example, this picture is really good. For example, in Burkitt lymphoma, there is one common translocation, which is H14 translocation. So there is translocation of the chromosomes between the 8th chromosome and the 14th chromosome, chromosome 8 and chromosome 14. The result is increased production of MYC, which is nuclear transcription factor. So the cells will proliferate a lot. There is so much increased cell division. So the cells will proliferate a lot. So we will see that the Burkitt lymphoma is very aggressive. Just the tumor cells proliferate a lot all the time. So we will expect to see static sky pattern within the tumor everywhere in the lymph node involved by the lymphoma. So because chromosome 14 is for immunoglobulin production and MYC is located in chromosome 8. So when there is translocation, the MYC location will be translocated next to the location for immunoglobulin production. B cells have to produce immunoglobulin. So when this gene is very close to the locus for immunoglobulin, MYC will be produced along with the immunoglobulin. So the tumors will have too much MYC. They will have very high proliferation index. Another example is BCL2 in follicular lymphoma. One common translocation is translocation 14-18. Chromosome 14 again is for immunoglobulin, whereas chromosome 18 is for BCL2. When there is translocation, the locus for BCL2 is located next to the locus for immunoglobulin. B cells produce immunoglobulin, so BCL2 is produced along with the immunoglobulin. So the pathogenesis of follicular lymphoma is different. In Burkitt's lymphoma, the pathogenesis is too much proliferation, whereas in follicular lymphoma, the pathogenesis is too little apoptotic cell death. So the cells will grow as usual, very slowly, but the cells just never die, So if we compare between these two, we expect that Burkitt's lymphoma will grow very fast, will be very aggressive because the proliferation is very high. On the contrary, follicular lymphoma, the pathogenesis is not increased proliferation. So the cells grow slowly, but they just don't die. So just like the tumors will be indolent. So in leukemias, acute leukemia, myeloid leukemias, there are some common translocation that may influence self-renewal, including PML RARA fusion gene, which so there are some common translocations that I think you should memorize. In chronic myeloid leukemia, which is one example of chronic myeloproliferative disorders, the common and the translocation that must be detected in order to make the diagnosis is 922 translocation. So this is called Philadelphia chromosome. This translocation results in production of chimeric protein, which have tyrosine kinase activity. So these neoplastic cells will proliferate a lot, but the differentiation is still intact. So we will see maturing, we will see different stages of myeloid cells. We will see promyelocyte, myelocyte, for example, different stage band forms and segmented leukocytes within the blood, within the blood circulation. And the pathogenesis is this translocation. We call this translocation Philadelphia chromosome. This one you must know also. For AML, there are so many types of translocation, but the one that you must know is translocation 15 and 17. Translocation 15, 17. This will result in chimeric protein that promote self-renewal property of the hematopoietic stem cells, of the hematopoietic cells within the bone marrow, and the maturation will be arrested at the promyelocyte. So this one is a cause of acute promyelocytic leukemia, APML. This one is very important because this translocation will be overcome by administration of vitamin A. Vitamin A. I will talk about it again later. For ALL, there are also different translocations. MDS also different translocation. For lymphomas, there are only a few that I would like you to memorize. The first one is in Burkitt lymphoma. The translocation is translocation 8, chromosome 8 and 14. Chromosome 14 is for immunoglobulin. Chromosome 8 is for c-MYC. So translocation results in overproduction of c-MYC. c-MYC is produced along with immunoglobulin. The second one that you must memorize is follicular lymphoma. The translocation is translocation 14, 18. 14 is for immunoglobulin, 18 is for BCL2. This translocation results in overproduction of BCL2 along with immunoglobulin. So BCL2 is overproduced. So the tumor cells will have too much BCL2. The cells will never die. And the third one, mantle cell lymphoma. Mantle cell lymphoma. CD11 is for cyclin D1. 14 is for immunoglobulin. So the translocation will result in overproduction of cyclin D1. As you may recall, cyclin D1 is involved in cell cycle progression. It will bind to CDK, cyclin dependence kinase, and promotes cell cycle progression. So the cells will grow a lot. The cells will proliferate very quickly. So we expect that this type of lymphoma is quite aggressive. There are some known causes or predisposing factors for white blood cell neoplasms. For example, leukemia is associated with those with genetic instability, and also Down syndrome, and also neurofibromatosis type 1. Just like I would like to I usually call that disease von Reckring-Hausen syndrome or Tau syndrome. So these patients will be prone to develop leukemia. Some viral infections are known causes of leukemias or lymphoma. For example, human T-cell leukemia virus. So the name is very clear. It is a cause of adult T-cell leukemia or lymphoma. Okay. And EBV, Epstein-Barr virus. So the infectious disease caused by this virus is infectious mononucleosis. EBV infection is a known cause for Burkitt lymphoma, Hodgkin lymphoma, B-cell non-Hodgkin lymphoma in T-cell deficient patients, and also NK cell lymphoma. And another cancer associated with EBV is nasopharyngeal carcinoma. And H. human herpes virus AIDS is a known cause for primary effusion lymphomas. This one is so special because it's so unique, but it's not so common. So I don't think you have to memorize, but it's good to know. Not only viruses, but also bacterial infections can cause lymphomas. For example, H. pylori gastritis, the H. pylori, Helicobacter pylori, or pylori gastritis is a known cause for mouth stoma or marginal zone lymphoma. Other autoimmune diseases such as Sjogren disease and Hashimoto thyroiditis are also precursors for mouth lymphoma. For example, lymphoma within the thyroid gland is known to be caused by Hashimoto thyroiditis. Some other chronic inflammatory conditions including celiac disease or gluten-sensitive enteropathy. The patients will have chronic inflammation of the intestine, so their intestine is prone to develop T-cell lymphoma. And also HIV-induced T-cell dysregulation will cause B-cell lymphomas. Not only due to T-cell dysregulation, but HIV patients are prone to be infected by other agents. For example, the EBV infection is also common within the HIV infected patients. So lymphomas within the HIV infected patients may be associated with HBV. And so radiation and chemotherapy are associated with different myeloid and lymphoid neoplasms, and smoking, particularly the benzene component of it, is a cause of acute myeloid leukemia. So may I have a break here, and next session will be focused on the different types of white blood cell neoplasms.